Hi, I'm Steve North,
And I'm Amanda Martin.
and thanks for joining us for one of our webinars with Mid-Atlantic Telehealth Resource Center.
Today we're going to talk about the 101s of school-based telehealth.
So I think one of the places we need to start is this idea of what is telemedicine, what's telehealth, what's virtual care. It seems that every day somebody wants to add another term to the bucket that we have, including telepodiatry. So when I think about telehealth, I think of it as sort of an all-encompassing area that includes remote patient monitoring. So how do we take care of grandma's CHF at home? And how do we do e-health? So sort of a concept of a patient portal and web-based interactions without live video. And then finally, telemedicine is a subset of this where there's interactive video and patients are receiving direct care from a healthcare provider and able to interact and perhaps use some diagnostic equipment to see what's going on with the patient. Telehealth terms are incredibly important and very confusing. I assure you that before the end of this session, I will mess these up. So when you're thinking about telehealth, you need to think about where the provider is located and where the patient is located. This is the old hub site where the provider is located and spoke site where the patient's located. But over the last several years, the terms distant site and originating site have sort of replaced that. So the distant site can be just about anywhere from a hotel room in California to a bunker from a healthcare facility or healthcare system where they see ICU patients from all across a three-state area and monitor everybody in one location. The originating site is really the much more important site, and that can be just about anywhere the patient's located. But this is the site that is critical as we think about reimbursement, licensure, and finally think about follow-up care for that patient. How do we make sure that we know where the patient's located, that it's a confidential location, and that the provider seeing that patient is licensed in that state? I've got a license in North Carolina and in New York, so I can see patients there. My patient may be on vacation in Wisconsin and call me and ask for a refill. And if we're doing telehealth, I'm not able to prescribe medication and technically cannot provide medical diagnoses to that patient because I don't have a Wisconsin license. The basics often are a telehealth cart like this that has a camera for two-way video, a monitor so that the patient can see what's going on. They can see the provider, but they can also see the images from perhaps the otoscope or the exam camera. Finally, a stethoscope is critical as well. This is to provide comprehensive patient care. And one of the important parts is who's that presenter at the other end. We'll talk about that a little bit more today and then in other sessions that we have. But the presenter needs to know where to place the devices, how to run the equipment, but they really don't need to be a trained or licensed healthcare professional from our perspective. Perhaps for billing regulations or state regulations they do, but for just operating the equipment, a school secretary, a well-intentioned parent who's done some HIPAA training and also feels comfortable with the equipment is ideal. Specialized equipment can be added on for endoscopy or other things, but that's really beyond the scope of the care we're talking about today. There are a variety of medical peripherals, like we mentioned, stethoscopes, otoscopes, and exam cams are some of those.
So we talked a little bit about telehealth, but now school-based healthcare. Why healthcare in schools is the question. Starting off, thinking about kids missing school. We have a superintendent in our community who likes to tell a story about the kid who casually misses a day of school every month. And he's so sweet and wants to stay home with his mommy that she lets him. And
Right.
so this child and his family get in the habit of missing about a day of school here and there, 1 day a month. But when you add that up over a habit, if it starts in kindergarten, it carries on through elementary and very likely into middle and high school. And you add that up to 10 days, school days every year for over 13 school years, you're missing almost an entire school year spread out. And this doesn't include actual planned vacations or actual illnesses. And what the superintendent realizes and made a point of saying is that casually missing school for minor things is not okay, and it does add up. And you have kids who end up not graduating and not achieving like they could. In the Health Affairs in 2008, there was an article about the increase in average life expectancy for high school graduates compared to non-graduates being 7 years. And in fact, that number goes up the more schooling you have.
Now, I'm not sure if that continues through like residency and fellowship. The data says that it's 16 years for a postgraduate degree. That's sort of where it peaks. I think that my life expectancy is actually on the downswing because of too many late comments.
You've peaked. Yeah. Okay, gotcha.
So school-based health centers are an amazing concept that have been around for about 30 years. And the School-Based Health Alliance is the national advocacy and educational organization for all school-based health centers. The goal of school-based health centers is really to treat kids where they spend the majority of their day. I think that this definition of school-based health centers from the School-Based Health Alliance website is excellent. We're talking about that interplay between health and education and how health status impacts educational outcomes, but at the same time, as we saw in the previous slide, educational outcomes impact your health status long term. So this is how do we provide kids with better asthma control so that they're not having difficulty breathing through the spring and up until final exams? How do we do a better job of taking care of their ADHD at school? And really, this is a way for healthcare providers to partner with their schools to improve the overall health of the students. CHIPRA, the Child Health Insurance Act of 2009, for the first time really provided a federal definition of what a school-based health center is. And this is located in or near a school, and it's organized by the community, and it really represents the interests of that community. So my coming into rural New Mexico and saying, I know exactly what needs to be done, probably isn't best.
Because you're not from rural New Mexico.
Right, because I live in the mountains of western North Carolina and I've been in New Mexico once. And you need to have a sponsoring facility or a sponsoring agency that oversees the management. That could be a variety of things. We'll come to that in a second. You got to provide some level of primary health care. So do you treat sore throats? Do you treat earaches? You also look at asthma and look at some of the prevention aspects that's critical to primary care medicine. And then in every state, there are state regulatory requirements that need to be satisfied in one way or another to be defined as a school-based health center. So this idea of a sponsoring facility is one that often ties people down. And honestly, it can be about any nonprofit agency in the world or a school system, as long as it's not a for-profit entity. The for-profit doc in a box probably isn't going to be the best sponsoring facility if you're looking at developing a school-based health center. Now, they can provide the care, and you could contract with them, but they should not be perceived as the lead agency. Also, having a for-profit entity as your lead agency is really going to prevent you from getting any grant funding. That's the topic of another webinar.
So when you're talking about the sponsoring facility, their job is not necessarily to provide the care.
Right.
It could be the care.
Absolutely.
Not necessarily, but they're more like the backbone.
Right.
The
And
entity that
coordinates, brings all the parties together at the table, make sure that the goals and objectives are kept in mind, that the organization is there to improve the health of the students. And
they may also be the fiscal agent.
Yep.
And they may be the one to call community meetings.
Yep. And make sure that everybody's voice is heard.
All right.
Yeah.
Thanks. Okay, so the School-Based Health Alliance, who really are at the center of school-based health centers in the US, list out core competencies that are very well developed. And I can't stress enough that if you need more details on this, to visit their website and look for core competencies. It's right on the front. But those competencies are around access, meaning that it's actually available to every kid, and that the care is focused on those students and not for the benefit of the healthcare provider.
And so whether they have insurance or not,
Still have to see them.
you still do see that. It's not a burden. Right. And whether they're a undocumented immigrant.
Still see them.
Excellent. All right. So
Whatever
all
their
kids.
needs are.
Great.
Mhm. And it's specifically focused on that school and that school's needs. And again, not on the needs of the pediatrician to expand their reach or corner the market on patients.
Right.
And then the accountability to financially to the sponsoring agency, as well as to the schools served and the community served. And then the effort to make a population level impact, which is talking about things like immunizations and screenings.
Obesity prevention, screening for risk-taking behaviors. Absolutely. Yeah.
And then that last one always gets me, that sound business practices, because there's not a lot of money in school-based healthcare. I don't know if you knew this or not.
I'm well aware.
Mhm.
Yeah. Yep.
Yeah, but the bricks and mortar school-based health centers that do exist around the country, some of them do okay.
Absolutely.
A lot of them are largely grant funded, but they're definitely a community effort and don't have a lot of money coming in.
And all the telemedicine programs that we know of are pretty much grant funded.
Pretty much.
Yep.
Right. So here's the thing. This is where they intersect, right? This is where we say telemedicine is such a good idea. School-based healthcare is such a good idea. A lot of the bricks and mortar school-based health centers are at schools with 1,500 kids, 2,000 kids, bigger even, or maybe they're on a campus where there's a 2,000 student high school sharing land across the parking lot from a 2,000 student middle school. Unfortunately, where we live, in the very rural part of Western North Carolina, we only have 2,000 kids in the whole school district, and they're spread out over 7 schools.
Right. And so this is scenic B-Log Elementary School.
Isn't it cute? 48 kids?
I think this year it's down to 48.
48 kids are in kindergarten through 5th grade at B-Log Elementary. And they use all 3 of those buses, but they're not full.
Right. And this is about 20 miles or a 45-minute drive from the nearest doctor's office.
Right. And there is a town with a doctor's office just 45 minutes away.
Only 45 minutes away. And parents don't always work in that town. No. Yeah.
So this is where school-based healthcare by telemedicine starts to suddenly make sense, because it would not be practical to build a clinic building or even put a trailer in the parking lot at a tiny school like B-Log or the other schools in the school district. But if we can provide the care by telehealth, we can halfway make it make sense financially, right?
Yeah.
Yeah. So school-based health centers around the country, though, based on this map from the School-Based Health Alliance, right?
Yeah, based on their 2013-14 census data.
All of those pretty blue dots represent school-based health centers. And if you notice, they are largely in urban areas, pretty much focused over the cities. So we're proud that in North Carolina, we have lots of school-based health centers. But even in North Carolina, they're predominantly in the cities and not in the rural areas.
Yeah, that's true. You have some states like New Mexico that have a broad spread of school-based health centers. I think they have over 100 in the state. But by and large, predominantly rural states, if you look through the midsection of our country, they don't have access to healthcare at schools. And the School-Based Health Alliance is currently working with the Maternal Child Health Bureau of HRSA to expand the number of kids who have access to school-based healthcare by 30% over the next 4 years. And to do that, we believe that we really need to use telehealth to help increase those numbers and increase the spread of these great services.
How do we do it? We have an example of our program specifically and a short video to share with you that was made a few years ago, but gives a very good firsthand example of how it can work.
I don't have much gray in my beard.
Yeah, and I think my hair was a different color then too.
All right, great.
Enjoy the video.
In our community, accessing healthcare is a major challenge for many people due to barriers of geography, windy mountain roads, and also a lack of healthcare providers.
We feel we're very fortunate to have the telemedicine program in our school.
The advantage of providing health care for kids at school, it's often difficult for family members to come down and pick them up and take them to a doctor's visit. If mom or dad can't make it, she often ends up in the emergency department at 8 o'clock at night for something that could have easily been treated through a school-based health center.
The quality of care was phenomenal. By the time we would have been waiting for the doctor, he had already had his medicine. Not only did it help me to not miss so much work and Liam missed so much school, but we were able to be on the road to health.
So school-based healthcare by telemedicine can be and is arranged in lots of different ways. There are lots of different models. None of them really look like this airplane on the screen, but I did want you to think about that there's lots of ways to set this up. Our program is only one of those ways that it could be arranged. So there are a few things, though, we would say are minimum requirements. We actually put this list together with a group of people through the School-Based Health Alliance who are already doing school-based telehealth. As what the minimum requirements would be. These may look very similar to those core competencies we talked about earlier from the School-Based Health Alliance. So it's got to be care available to all students, not just the ones who can afford to swipe mommy and daddy's credit card. Should provide primary care services. Other things like behavioral health are really important. Dental is really important. Nutrition is really important. But you're not a school-based health center if you're only doing one of those. Some minimum equipment requirements, so not just video conferencing, but also that stethoscope, otoscope, exam camera, and continue to collaborate with the school, and very critically, sending information back to the primary care provider identified by the patient and their family, because any care that happens without involving the primary care provider is risking being, well,
not respected, and perhaps sort of, if you're practicing outside of your healthcare community, if you're not seen as an integrated part of that, people don't refer to you, people don't respect the decisions that you've made. And so the more we can get that information back to primary care providers, the better. Because on Saturday, when the antibiotic we sent in for Johnny's ear infection isn't working, we rarely get that phone call. It's the primary care physician, and they need to know what antibiotic we prescribed.
What got started. Okay, so tell us about the first kind of model.
Yeah, so one of the great ways to use telehealth is in bricks and mortar school-based health centers. And this is one that gets a lot of attention, especially in large entities that are trying to add telepsychiatry, add nutritional services, bring in something that they can't provide full-time at a specific location, but would like to have intermittently. And I think this is a great way to think about bringing in specialty practices. You know, one example of this is kind of what we did. Several years ago, we had the opportunity to partner with a local pediatric cardiology group. And we were looking at ways that they could use telehealth to reach patients in our community about 60 miles away from their offices who had been lost to follow-up. That's a great term in specialty healthcare. So those folks who, for whatever reason, didn't make it back for that subsequent visit. And in our case, we had a pretty healthy football player who had been hospitalized at age 11. And he was a big kid, actually. BMI was greater than 99th percentile. He had hypertension at the time, BP of 160/90, a little bit of renal failure because of the high blood pressure at a young age. And he was started on medicines in the hospital. He made one follow-up visit. And the reason that happened was mom had several other kids. It was hard for dad to get off work to take him. And while Medicaid paid for the visit, paid for the medications, they didn't pay for gas money. They didn't pay for lost wages. or for food along the way. And that made it really hard. So when we had this opportunity, we took our zip codes and provided them to the pediatric cardiology office. They ran their lost to follow-up kids. We found about 15 patients in the area that we were serving at the time who'd been lost to follow-up. And we were able to reconnect them at school. So another example is our friends down in Henderson County, North Carolina. Tammy Greenwell is the Chief Operating Officer of Blue Ridge Community Health Services. They have 4 high schools and 4 middle schools that have school-based health centers. And they're a federally qualified health center, and all of their school-based sites are part of the FQHC, but they can't provide therapy at all of them. And so what they've done is use telehealth to bring their therapists from the office to the schools, both for urgent visits and sort of in the context of integrated care, and also for scheduled follow-up appointments. And they've had some tremendous success with that. Over the last year, they've also been looking at nutritional visits, and they've done a few with some benefit, but their real focus has been on connecting LCSWs to the schools to see kids who have complex mental health needs.
That's great. So another kind of model that's using telehealth to in school-based health centers is expanding the reach of existing school-based health centers. So in this case, we're talking about a case, for example, where one provider is rotating between sites, maybe drives to one site on Monday, to a different site on Tuesday, and yet another one on Wednesday. By using telehealth, that provider could stay in one spot and still be accessible to all of the school-based health centers every day, and rotate by clicking from different connections instead of getting in the car and driving. The presenter or nurse at the end where the provider is not can be the presenter, and it would even allow for comprehensive physicals in a way that 100% telehealth might not.
Right, because we don't do testicular exams
No, we don't.
for sports physicals via telehealth.
No, we don't.
Good, all right.
We also have not figured out how to get vaccines through.
Yeah, the drones are coming though. I think it's going to work out for us pretty well.
So eventually.
Yeah.
But in the meantime, if you have school-based health centers that are not staffed 100% of the time,
right,
they could share a provider by using telehealth.
Absolutely.
And they would be staffed 100% of the time.
Yeah. And our friends down east, Pender Alliance for Teen Health, is doing this and connecting 3 school-based health centers. There's some examples in Oregon and throughout the country where this model is being used. And then there are programs like ours that are entirely virtual. So we don't have a bricks and mortar office at all. We've got 2 family nurse practitioners, and Jack teaches at the community college and sees patients from his office there. And Tanya teaches at Western Carolina and works for us when she's not teaching nurse practitioner students. And she then sees kids from her home and through actually a 4G hotspot. And it's pretty amazing. She doesn't have better connectivity in rural Madison County. But really, the idea of the entirely virtual program started at University of Rochester in about 2001. And I happened to do my residency and fellowship there and got to work a little bit with Neil Herendeen and Ken McConaughey. They started a program connecting Head Start programs and elementary schools to about 14 different pediatric offices across the Rochester, New York area. And they had a store and forward, initially, telehealth program that they began to use to send images of an ear and some history to the patient's primary care home to get treatment without the kid needing to sometimes get on a bus and travel across town to be seen. This program is the most well-studied program in the country, and there are multiple articles that they've published, and you can find those through a simple Medline search. But this model has been expanded upon and replicated across the country, and I think has great potential to continue to grow as the technology changes and improves.
This is not a for-profit virtual care company that happens to operate in a school, right? It's not a kiosk in the front hallway for kids to come in and swipe their credit card and be seen.
Mhm. It's not exclusively sports medicine at the sidelines. So there are a lot of focus around concussions, which is appropriate and great. And how can we use telemedicine in that context? And that's school-based healthcare, but it's not a school-based health center. You really need to tie into the whole student population to serve all the kids and not just treat the initial concussion, but be able to work and communicate with teachers over time to monitor how that athlete is doing. Or the kid who fell off his four-wheeler and got a concussion.
So what we're also not talking about are the speech therapy, occupational therapy, physical therapy kind of services that are part of an IEP.
Right. So those can be provided via telehealth, and it's a great way. You can improve the frequency of care that child gets their speech therapy. So instead of one 15-minute segment every week, they get 3 20-minute sections a week, and the repetition is there that my speech therapist colleagues say is so important. But
now we had an example.
We did.
In our community, we used it at one of our schools. We did speech therapy through our network for a little while. And what it meant for those kids is that they were only out of the classroom for the time of their speech therapy appointment.
Mm-hmm.
Prior to us being there, a handful of children were bused to another school to receive services.
Yeah.
And so 5 kids left school for essentially the whole day. So they could go, 4 of them wait while the 5th had their therapy, and then they were all bused back.
I heard that was a behavior management nightmare.
I suspect it
Yeah.
was.
Yeah.
Not to mention they missed every 5th day of school.
Absolutely. So, and it's not a bus. And the buses are great. They serve a need, especially in urban communities. You can bring telehealth in there and provide dermatology and provide cardiology, but that's not what we're focused on.
Right. So when we talk about our soapbox, we're really talking about, if you're going to call yourself a school-based health center, you need to be more than just cherry picking the.
Don't cherry pick,
Easy
and be
experience.
available and work with the school. Yeah.
All right. So we've been at this for a while,
Mm-hmm.
and we have definitely learned some lessons. We could go on and on about our lessons learned, but one of the big ones is that it's not about the equipment. Now, that said, we'll probably record a webinar about equipment, so look for that. But that's not the hard part. The equipment requires people. It requires people both to want to use it and also to operate it. Who the presenter is matters a lot.
Because they're an advocate for the program at the school.
Mm-hmm.
They're the one who represents your program, and you need to support them. Yeah. Scheduling is really different than my bricks and mortar practice. So I have a day job, and when a patient comes to see me, they've been told your appointment's at 7, not 7, I'm not there that early. Sorry, at 10:20. And they come and they're checked in by the person up front. The nurse brings them to the room, checks all their vital signs, enters them into the computer. I walk in, things are great. Providing care in schools is a whole lot more challenging because you're now trying to manage 3 schedules. The student schedule, so do you really need to pull them out of the math test to look at their sore throat or recheck their blood pressure? Probably not. You could do it during the study hall. The school nurse or whoever your presenter is, how do you manage that person? And then in our network, we're at 33 schools. So how do you make sure that the provider has a slot? And we use a single scheduling person to try to make this work. A supercomputer may be needed down the road.
If we
but
ever
right
lost
now,
her.
yeah, if we lose Lacey, we're in big trouble. Yeah.
The next thing, if you're in medical, you know what HIPAA is. If you're in the schools, you know what FERPA is. But let me just tell you, if you're one or the other, well, they're essentially the same thing. They have different rules, but they cover a lot of the same stuff. It's about not sharing information that's not yours to share. So every school-based health center, and certainly every telehealth school-based health center, has to address HIPAA and FERPA in their practice. So if the presenter, for example, is a school nurse and a school employee, they have access to records that are protected by FERPA, but because they're also presenting a patient for healthcare, now suddenly they have access to information that's protected by HIPAA.
Right, and this is more important, or equally important, when the kindergartner is sent to be seen for what the teacher believes is pink eye.
Mm-hmm.
And if the provider says, it's in one eye, it's in combination with a runny nose, and they just got a new cat, I'm pretty sure this is allergic rhinitis, or I'm sorry, allergic conjunctivitis, rhinitis being the nose. Unless there's a HIPAA-FERPA agreement in place that the parents have said, yes, that provider can tell the teacher that this isn't infective, that kid can't go back to class. And that's where you really need it.
So it's not saying it's impossible, it's saying that you have to address it and work out some examples so that you can explain it to people. Early on in our program, I had a parent tell me that they wouldn't ever use it and they would never sign their child up for care through our program because her child's medical record was none of that teacher's business. And she could just imagine the teacher thumbing through every medical visit the child had ever had in her life. And that is not what we're doing.
Because most classroom teachers barely have time to do their own jobs, let alone go looking through a kid's medical record. Yeah. For us, we started this program, our first carts went into place in 2011 in a small rural community. And we were bringing in both a change of where you receive healthcare and also how that healthcare is delivered. Schools weren't thought of as a place to see the doctor. And what is this telemedicine thing? We're seeing now 6 years later that as we bring on new schools, they are much more receptive to the idea. Telemedicine is sort of more common. There are ads about it during football games, but it's still not, entirely accepted. So how do you provide education for a school and parents and a community that you're trying to provide care there?
Right.
Yeah.
If I had it to do again, I would line all the parents up and explain it to them individually, one at a time.
I would also show them all their own ear on the monitor, because
Mm-hmm.
when you've seen the inside of your own ear, you're sold.
You're
it's
pretty
awesome.
much into it.
Yeah.
But it definitely is a very slow growth curve. I wish I could say that we were booked up solid right from the start, but it just isn't true.
Yep.
It takes a long time to explain that to people. One of the keys that we have learned, though, is that very last one, boots on the ground, is sort of a silly phrase, but it's really important to have somebody who's in the community, who's in the school, who's advocating for it. We have program directors that each cover somewhere around 10 schools, and they visit those schools frequently. They're available as backup presenters. They manage all the marketing in that community. So if there's a community festival or a PTO meeting or anything like that, the Chamber of Commerce, they're the ones who are there talking about the program, explaining it over and over again.
And showing people their eardrums.
And showing people their eardrums all day long.
Yep.
Mm-hmm.
Yeah. So this is the first of our webinars. And depending on when you watch it, you may be able to click, right to the next one in the queue. But we're going to talk about some additional topics over the next few months, and they're listed here. We're doing this as part of the Mid-Atlantic Telehealth Resource Center, one of the federally funded telehealth resource centers across the country. And through our role in that, we consult with programs across the nation. And we'll be happy to talk with you some more about what you're interested in doing. So here's our contact information. Feel free to drop us an email. We're also going to set up over the next month or so an online forum where general questions can be posted and we can respond to them, and other people with expertise can be part of this conversation as well. Because many of you are probably already doing this in your own communities and have experiences that need to be shared. Thank you.